a multinational trial of Prasugrel for sickle cell vaso-occlusive events. Sickle cell anemia is an inherited blood disorder that is characterized by painful vaso-occlusive crises for which there are few treatment options. Platelets mediate intracellular adhesion and thrombosis during vaso-occlusion in sickle cell anemia, which suggests a role of antiplatelet agents in modifying disease events. Children and adolescents 2 through 77 years of age with sickle cell anemia were randomly assigned to receive oral Prasugrel or placebo for 9 to 24 months. The primary endpoint was the rate of vaso-occlusive crisis and a composite of painful crisis or acute chest syndrome. The secondary endpoints were the rate of the sickle cell-related pain in the intensity of pain, which were assessed daily with the use of pain diaries.
Hey everyone, this is your NCLEX review on sickle cell anemia. Sickle cell anemia is an autosomal recessive trait pattern, which means that you have to get it from both sets of parents in order to have it. So you usually see a picture where the mom has the gene and the father has the gene, and they pass it down to one of their kids. In the picture, there's always 4 children, and one of them has the sickle cell anemia. And that's because there is a 1 in 4 chance, or a 25% chance, that you will have sickle cell anemia if both of your parents carry the trait. So what's the problem? Well, we can look at the name to determine what kind of problems that we will have to know for NCLEX. So the name, sickle cell anemia. Let's start with the first part, the sickle cell. So the red blood cell will have an abnormal shape, and it will look like this. So that means that it is more prone to clumping together in the vessels. All right? That's one problem that we definitely have to look out for, and we'll talk about that later. The second thing you need to know is that the patient will be anemic, hence the name sickle cell anemia. And that's because a normal red blood cell has a lifespan of up to 120 days, whereas a sickle cell only has a lifespan of up to 20 days. So you'll see that the patient will be anemic because the red blood cells are constantly dying and the body has to make more. On the lab value, you will notice that the reticulocyte count of a person with sickle cell anemia will be elevated because of the short lifespan of their red blood cells. I know that's a lot, but basically, the reticulocyte count is important in sickle cell anemia, right? So, the term you need to know is sickle cell crisis, all right? And that's when your patient gets into trouble because their blood is now really thick and clumped together, all right? And that will cause a lot of problems for your patient really fast. Number one, all right, is that your patient will be in severe pain. This is a very painful problem. Number two, the body's not getting the oxygen it needs, so the patient will have poor capillary refill, okay? They will complain of shortness of breath. They will be cyanotic or blue, all right? You'll be able to see that. Also, because the blood is clumping together and not moving, that puts your patient at risk for pressure ulcers. Number one, we have to figure out what are the causes. The main causes for sickle cell crisis are going to be hypoxia, okay, and dehydration. Hypoxia and dehydration. So our treatment will focus on correcting those issues as well as taking care of that pain that I talked about. Well, it's so painful because the blood is clumping together again, and it's basically killing the tissues. It's leading to the necrosis of the tissues. That will cause the pain. Very simple. We're going to hydrate with IV fluid. We're going to encourage them to drink PO fluid. We're going to give oxygen via nasal cannula. Right? We're going to give pain medications for the pain to help them relax. You may also need to transfuse with blood. So you may also need to give blood on top of all those other things that you've done because the patient will be anemic.
There were no significant differences between the groups in the secondary endpoints of diary report events. The safety endpoints, including the frequency of bleeding events requiring medical intervention, of hemorrhagic and non-hemorrhagic adverse events that occur while patients were taking Prasugrel or placebo, did not differ significantly between the groups.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules, such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
A total of 3,041 patients underwent randomization at 55 sites in 13 countries across the Americas, Europe, Asia, and Africa. The rate of vaso-occlusive crisis events per person year was 2.30 in the Prasugrel group and 2.77 in the placebo group.
Dr. Hammond, you're reporting today at the American Heart Association results of the Triton TIMI 38 trial. I'd like you just to describe the trial initially.
Sure. Well, thank you. We did describe the Triton TIMI 38 trial today, but let me tell you why we did the study, and then a little bit about how we designed the trial. We asked an overarching scientific question, which is whether we could come up with a regimen that would produce a higher level of inhibition of platelet aggregation. That is, decrease the ability of platelets to clump together and decrease the ability of a clot to form. And if we could identify such a regimen, would it be associated with a reduction in events in patients who undergo percutaneous coronary intervention and have a stent implanted? And the other question would be, how safe is it to actually use such a regimen? Now, we were able to test these questions in the Triton TIMI 38 study because there is a drug that is an investigational third-generation thiionopyridine called Prasugrel, which does produce higher levels of inhibition of platelet aggregation and does so much more rapidly than the current standard, clopidogrel. So our trial involved 13,608 patients, 30 countries around the world, 707 sites. And we randomized patients with an acute coronary syndrome to receive either standard therapy with clopidogrel, a loading dose of 300 milligrams and maintenance dose of 75 milligrams, or the investigational regimen, Prasugrel, loading dose of 60 milligrams and a maintenance dose of 10 milligrams.
This one of the interesting things about this trial is that you did compare to the standard clopidogrel, the second generation.
Correct.
You described for me just briefly the findings, the endpoint first of all.
Sure. A double-blind study drug was to be given for a median duration of at least 12 months, a minimum of 6 months, and a maximum of 15 months. It turned out in the trial that we did have a median duration of therapy of 15 months. So when we talk about the end of the study, it's 15 months. We did have some key pre-specified safety endpoints, TIMI, major, non-cabbage bleeding, and life-threatening bleeding. We also looked at a number of secondary endpoints, including stent thrombosis.
Let's talk first of all about the primary endpoint.
We observed overall in the trial a highly statistically significant 19% reduction in the composite primary endpoint, cardiovascular death, MI, or stroke, with Prasugrel. 138 events were prevented with Prasugrel compared to clopidogrel. The number of patients who would need to be treated to prevent one event was 46.
The whole issue of what to do with patients who have high on-treatment platelet reactivity continues to baffle all of us caring for patients after PCI. Now in JACC is a report on the TRIGGER PCI study. This trial studied just such patients and evaluated the efficacy, safety, and antiplatelet effect of Prasugrel as compared with clopidogrel, but practically it gets to whether Prasugrel can correct high on-treatment platelet reactivity and improve clinical outcomes in patients undergoing elective PCI. Here is what they did. They took patients with high on-treatment platelet reactivity after PCI and randomized them together with Prasugrel or clopidogrel. Platelet reactivity of the patients on the study drug was reassessed at 3 and 6 months. Now, importantly, the study was stopped prematurely for futility because of a lower than expected incidence of cardiac death or MI. But what the researchers found was that in patients assigned to Prasugrel, platelet reactivity was decreased dramatically compared to those who continued on clopidogrel with a minimal cost of slightly increased bleeding. So what does this trial teach us? Switching from clopidogrel to Prasugrel in patients with high on-treatment platelet reactivity results in effective platelet inhibition, no question. However, Given the low rate of adverse ischemic events after PCI with contemporary drug-eluting stents in stable coronary disease, the clinical utility of this strategy could not be demonstrated. It is yet another example where the science seems sound, but we do not see a change in clinical events. I'm Peter Block, and this is a CardioSource Heart Minute.
Among children and adolescents with sickle cell anemia, the rate of vaso-occlusive crisis was not significantly lower among those who received Prasugrel than among those who received placebo. There were no significant between group difference in the safety findings.
At the American Heart Association meeting in 2014, one of the topics of conversation and great debate is certainly dual antiplatelet therapy. And we know that following PCI for non-STEMI, a P2Y12 antagonist is recommended for 1 year. After some of the data here, that probably is going to continue for a while. What about pre-treatment? Well, as of ESC in 2013, some surprising results from ACOAST and PCI, and we're talking about the effect of Prasugrel pre-treatment strategy. Now, I'm with Dr. Gilles Montelesco, who is an MD, PhD, and chair of the Department of Cardiology at PTA Hospital, and we're talking Paris at the Institute of Cardiology there in France. Now, you did the original presentation, and I believe it came out of the New England Journal, you said. So let's talk about the original ACOAST results before we get into what's coming up in JACC. What did you find?
Well, interestingly, what we looked at is that end-STEMIers presented to the emergency room or the cardiology department being randomized for pre-treatment with Prasugrel immediately at presentation versus no pre-treatment when you decide for an invasive strategy within 48 hours. And what we found is actually pre-treatment, even with one of these new drugs, very potent, rapidly active, did not protect the patients better against ischemic events. And actually the number of ischemic events was exactly the same in both arms.
Did that kind of surprise you?
Yes, because we lived with the idea that pre-treatment was good coming from cure performed almost 2 decades ago, and that was a whole different issue. Conservative management, patients didn't go to the cath lab easily, very few PCIs, that was only performed in 20% of patients. So it's a different story, different era also.
Right. Now, this is in the December 23rd issue of JACC, and what are you looking at?
And actually we had more bleedings, but no efficacy with pre-treatment.
So you had the cost, but you had no value for the cost.
There was only harm.
Yeah.
Only harm. So it's just like with 2 centimeters in the past. We started by giving these drugs early on, and it became class 3 because there was more bleeding and no benefit. Exactly the same story. And that was a surprise to us, no benefit at all. And of course, in this population, wide population, 30% of patients didn't have PCI. Those going to cabbage surgery, no benefit of pre-treatment. Those medically treated, those with normal coronaries after the angiogram, no benefit. So it was very important to look at the PCI subgroup of patients because if anything, pre-treatment has been invented for PCI.
Mike Gibson and Usman Babur here from Sky 2015. Usman, you just presented the results of the Prometheus study. Tell us a little bit about what the question was you're trying to answer and the design of the trial.
Well, thanks, Dr. Gibson. The Prometheus study is basically a study looking at real-world patients, those patients who are not usually enrolled in clinical trials, and trying to understand in a real-world context how is Prasugrel being used, what are the determinants of Prasugrel use, And also, what's the safety and efficacy profile of Prasugrel as compared to Prasugrel as compared to clopidogrel?
Sure.
And that was the basic fundamental question we were trying to ask with this study.
And how many centers did you have? What was the scope?
So what we ended up doing actually is we used a little bit of a novel approach to conduct this study. We went to different medical centers across the United States. We found 8 centers. Each of these centers maintains their own database on patients who come in with acute coronary syndromes, get treated with clopidogrel or Prasugrel. And these centers provided us data on their patients between 2010 and 2013. And in total, in this manner, we were able to generate a data set of 19,914 patients,
Right.
all of whom were treated with either clopidogrel or Prasugrel, underwent PCI with stent implantation. All those data were then sent to us at Mount Sinai, where we aggregated, harmonized, and generated one unified patient-level pooled data set. And the primary endpoint of this analysis was the rate of MACE, which was defined as death, MI, unplanned revascular stroke at 90 days from the time of PCI.